I would like to welcome, besides all of you, Dame Professor Lesley Regan, who is the Ambassador for Women's Health from 2022. She was charged with developing a strategy for women's health by the government. So good luck to her with that. Lesley is also as the ex-president of the Royal College of Obs and Gynae, and is still a professor of St Mary's Hospital in London and Imperial College. She is the secretary of FIGO, which is the International Obs and Gynae, and also, I won't go on because it could take as long as the lecture, all the different institutions and research bodies that she's been involved or is involved with still. So at that I will just leave Lesley to do the talking rather than me, and welcome her to here.
Thank you. So thank you very much for inviting me, Sue. What she's forgotten to tell you is that we first met in the 1980s when I was the senior registrar in Cambridge and she was the junior registrar in Cambridge. And it's really a great pleasure not just to see Sue again in the flesh, as opposed to on a Zoom call or a telephone, but also to bump into some other people I've known from various parts of my life. So thank you very much indeed for asking me. So I'm going to start off by posing this question: why do we need a women's health strategy? It took me an awful long time to persuade the government, several governments in fact, that we needed one. And this is the reason I think we do need one. Yeah. Right, so this is a snapshot of health challenges. Don't worry, you don't have to read it all, because I'm going to go into them a little bit more. We've got a terrible problem with obesity in this country. We're the most obese nation in Europe. We've still got lots and lots of people dying of smoking. And we know that in pregnancy, 1 in 4 women are still smoking. And it's always those that are most disadvantaged and deprived. What you may be a little bit more surprised about is contraception has become incredibly difficult to access. Contraception, which we pioneered for the rest of the world, because of fractured commissioning. And that means that nearly half of all the pregnancies in this country, that's 800,000 maternities per year, are not planned. Abortion rates are rising, and I'm going to talk a little bit more about that in a moment. Maternal mortality is 4 times higher in Black women and twice as high in Asian women. If I was a Black woman in the UK at the moment and I was pregnant, I'd feel angry about that. And suicide is now the leading cause of direct maternal death during pregnancy and the first postnatal year. And of the suicides last year, and the Embrace report came out just last week, 1 in 4 of those maternal suicides were of teenage girls. 1 in 5 of the NH workforce are menopausal women. 1 in 3 women over 60 experience urinary incontinence. Now, you may be very, very upfront in your household and talk about periods and the menopause, but I bet you don't talk about urinary incontinence. Symptoms of cardiovascular disease vary dramatically between different women and men. And as a result, men receive their diagnosis later and their treatments later, and they have much poorer outcomes. And I think I'll be able to go on and show you a bit of that in a moment. And then osteoporosis and frailty, major causes of morbidity and mortality. And we desperately need some prevention strategies. So why a women's health strategy? That's what several secretaries of state asked me. And my response was always the same. Well, we're 51% of the population. We're 49% of the workforce. We undertake over 2/3 of all the unpaid caring roles in our society. But women's health really hasn't received the attention it deserves. And the dramatic variations in access and quality of services across the UK really are scary. I mean, I could spend the rest of the next hour talking about the differences just across London, the capital city, which everybody thinks of as being the most affluent. You know, if you get on the tube, on the Green Line, say, at Westminster, and you go out to the East End, 20-minute journey, and your life expectancy drops by 20 years by the time you've got to the other end. And women are experiencing extraordinary health inequalities and outcomes that could be so easily avoided. And I think one of the problems is that women's health has been underfunded for decades, And there's a problem with our structure because we don't have a health service, we have a disease intervention service. So we spend 124 billion, in fact the numbers have gone up now, treating disease, and only about 12 billion on prevention. And that just makes no sense. We all know that prevention is much cheaper to deal with than cure. And possibly it's because my generation, that includes you, Sue, and you, Steve, we were really taught to work in a disease intervention service. So this is the traditional view of what women need during their life course, emphasize the life course. We used to group them into sort of three broad groups: childhood, adolescence. I don't deal with the children, but the adolescents, reproductive years, and the post-reproductive years. And for the most part, with a few exceptions, which I've already hinted at, we've got very bad at, the contraception and the cervical screening are rock bottom low. Apart from those, we then waited for women or girls to turn up with a problem, and then we tried to put it back to right again. So there's also been a historical emphasis on pregnancy. But as you can see from this life course, which is going from 0 up to 58, pregnancy is actually quite a small part of women's lives. There aren't many women in this room today who've been pregnant for more than 2 or 3 years. And most of us are going to live until our 80s. So there's another 80 plus years to be catered for, which has been completely out of the spotlight. It's just not been focused on. And I spent many, many years doing research into a part of assisted conception and repeated miscarriages. Actually, it's the blot, it's a little dot on the landscape there, isn't it? Everything else is far, far more important. And I think the reason why the graph stops so dramatically at 50 is because when I qualified in 1980, when women became menopausal, they completely disappeared from view until they presented a bit later with problems. Now, if we went to, well, when I got out on the train at York Station today, if I got around with a microphone and asked every woman in the station, what are you going to die of? She will probably say cancer, and she's wrong, because the vast majority of us are going to die of heart disease or dementia or osteoporosis and frailty. And my worst dream is to have a combination of all three. But that's what we're going to die of. We're not going to die of cancer. And yet what I want to show you now in this talk is that we're not preparing women across the life course to have the best health that they can. And as a result of this, although we live longer than men, we spend a very, very long period of the latter decades of our lives in very poor health. So these are the two secretaries of state I worked with when I was president at the RCOG. And they're both interesting characters. I became very fond of Jeremy Hunt, actually. He does care an awful lot. Anyway, I digress. So they were always saying to me, but we've got plenty of this. And then they would point to me towards another maternity thing that they'd funded. And there was one particular day, and I'm not including the slide because it is a bit derogatory, when I just said to Jeremy Hunt, I said, for goodness sake, I said, we've got past the whole Margaret Forster thing and, Handmaid's Tale. Women are not just maternities. You think about women as incubators, and then they drop the baby and then they disappear. And he was really quite shocked. And by the time Hancock got in, he'd already persuaded the Department of Health that we needed to have a women's health task force. And here I am with Jackie Doyle-Price, who was the Conservative MP at that time, in November 2018, launching the Women's Health Task Force, which we both decided had to be launched on Woman's Hour, because I don't know about you, but if you hear it on Woman's Hour, it's definitely bona fide, isn't it? So we thought we would, and we co-chaired it together, and she was really good. She said, I don't know anything about women's health, she said, but I know which doors to open and which buttons to press. So it was a fabulous partnership, and we got a lot done. But when we gave the Department of Health this checklist about what we were going to look into, they said, oh, well, what about molecular biology and molecular genomics and cancer screening? So I said, no, we're not going to do that. I said, there's plenty of that around. We're going to do things that are really, really important in women's lives and which we've become, I think, hopelessly complacent about. So the most important thing we established with that task force, which I ran until I stopped being president at the end of December 2019, was that we needed to get everyone to think about a life course approach and how, as you go through your life, every decade of your life, your health during that decade impacts on what happens in the next decade. And it doesn't matter where you start and you get the light bulb moment, I've got to do something about this. You can always get it better if you stop, regroup and then think about preventative care for the decade ahead. And what I think's been so stupid about what the situation we now find ourselves in is that actually women's healthcare needs are entirely predictable. Because the vast majority of occasions when women go to healthcare professionals, they're not actually sick. They're trying to do maintenance things. They're trying to get their smear sorted out, or their mammogram done, or they're trying to get their painful periods sorted, or their menopause sorted out. And some of them, also for 4/5 of them will have a pregnancy, and they spend a couple of years possibly of their lives, but no more, pregnant and being looked after by the maternity system, which, as I kept saying to and Hunt, they've got this massive dollop of money and there's nothing for the rest of women's health. And I already mentioned my point about the menopause, but I think that's a really important point, that we now understand that there's a whole lifetime, or certainly several decades after women become menopausal. And I'm probably one of the first generations of women who are going to spend longer post-reproductive than I was reproductive. So it's really important that we get this right, because otherwise we're just going to spend a progressively longer time in poor health, which costs a lot more money. So let's look at those health challenges in a little bit more detail. So yeah, 1 in 2 mothers now are overweight or obese. And for those of you who perhaps are not in my specialty and Sue's specialty, we've had to change the WHO guidelines on what obesity means to sort of cater to the pandemic across the world. Everybody accepts that people are a lot fatter. I already mentioned about 1 in 5 mothers smoking during pregnancy. Sexually transmitted infections are rising. I remember about 15 years ago talking to someone at the Department of Health who thought that we should scrap syphilis screening because nobody had syphilis anymore. It is now almost getting to epidemic level. And as I said, contraception is increasingly difficult to access. We've got the highest teenage pregnancy rate in Europe. It's a lot better than it used to be, but it's still the highest in Europe. And as I say, the abortion rate is rising, and it's not rising in young girls, it's rising in 35 to 45-year-old women, because when you talk to them, they can't access long-acting reversible contraception, and they've already completed their families, or they've decided that they're not having children. But that really has been accelerated as well by the pandemic. So that seems to be particularly stupid because we know that contraception is the single most cost-effective intervention in healthcare. So whatever your specialty is, you won't get your return on investment to quite the same extent as with contraception. So we know globally, and I'll come back to global a little bit later, that's a really important thing because maternal mortality globally is still about 300,000 deaths per year. And if you can reduce unplanned pregnancies, you will dramatically reduce the death rate. But the most important thing is not stopping the unplanned pregnancies, but it's optimizing the birth interval. So if you can get a gap of 18 to 24 months between pregnancies, you have the very best outcomes. And if you have a pregnancy in less than 6 months or 12 months from the last baby being born, you have awful outcomes, including very expensive ones like prematurity, with all the incurred costs of neonatal care and death and brain injury. So all obstetric complications are reduced if you increase the birth interval. So the question I keep asking all these ministers and secretaries of state is, why is contraception so difficult to access in the UK when we know its benefits are enormous? And of course, it's always the disadvantaged and the marginalised girls and women who are the worst affected. And I think this is the answer. The commissioning has been so fractured and so siloed that primary care doesn't speak to local authorities, doesn't speak to secondary care. And perhaps most importantly, if you're in secondary care and you don't do your bit of the contraception commissioning right, you don't pick up the problem, or you don't pick up the expense of the problem, it goes somewhere else. And you can say that with all 3 of those silos. So there's not much incentive to get it right if you don't have to deal with the consequences when it goes wrong. So no systems leadership, no overall accountability for unplanned pregnancy. And that's just one example of women's health that I've been trying to hold people's feet to the fire about. Contraception, and you may have seen this film, this documentary by Davina McCall, who is working her way through all the women's health issues. She's done menopause, she's now onto contraception, And she said to me, what's the problem with it? So I said, well, you can't get long-acting reversible contraception like Mirena coils. And she said, what? She said, I've got a Mirena coil. I would, for her menopause stuff, which is, I'm not breaking confidence. She says it on the screen. And then she said, I tell you what, she said, you come on the programme, which aired on June the 8th of this year, and you put a Mirena in for me, and we'll show everybody how painless it can be. So I said, well, on screen? And she said, yes, why not? So I thought, okay, all right. So we did it on screen. And my payback was that she says to the camera in one of those sort of Fleabag moments, she turns to the camera and she says, fairy fingers she's got. So there we go. Anyway, it's really changed things quite a bit, because for 6 or 7 weeks after that documentary was broadcast, I'd have women coming into the clinic and saying, I want a Davina McCall. And so I think she's actually about to do for menstruation and menopause management and problem periods what she did for the menopause. So let's crack on, shall we? Maternal mortality, I've given you all those. I don't need to come back to that. And then I wanted to talk about the fact that having a health strategy is not a new idea. There are very few new ideas, aren't there, in life? But certainly this is not a new idea. And I've been involved in 2 previous, I think, quite influential reports. But the first one on the left was one that Sally Davies commissioned when she was the Chief Medical Officer, the only female Chief Medical Officer we've ever had. So perhaps that's why she commissioned it. And it was called The Health of the 51% Women. And what she did was look at key areas for action. She was one of the first people who stood up and said, obesity is having a terrible impact on women's health and reproductive health. She did a lot of other things as well. She talked about the menopause. She talked about her own urinary incontinence after 2 vaginal deliveries, which she always talked about because, of course, I was the obstetrician. So I always used to think she was having a bit of a go at me, but I said that was because she hadn't done her pelvic floor exercises. And but anyway, she did an enormous amount, and she got so much flack from the media, flack from the profession, particularly flack from government about that report, because it was telling people what they really didn't want to hear. And then during my time as president at the RCOG, we worked on this publication called Better for Women. And the key recommendation was 23, and I don't worry, I'm not going to go through them all, but number 1 was we must have an NHS-led women's health strategy, because when we get it right for girls and women, everybody benefits. So here's Sally's publications. I did it, worked with her as a senior editor, and Ed Mullins, who was then a trainee pixie. He's now my consultant colleague, I'm very happy to say. And he actually changed from being doing his PhD in fetal medicine and moleculars, and he's now become a public health women's health doctor, which I thought was a real coup. And as I say, we looked at missed opportunities. We looked at all those areas of unmet need: preconception, postnatal health, mental health, life course health. Roll forward to the Better for Women report, and we based this again on the life course. And that graph that I showed you of women's predictable health needs is the one that we used for that report. And then we looked at access to accurate education and information, prevention and empowerment, and fragmentation and access to services being so poor. And what we did in those 23 practical proposals was every time we made a criticism, and it was criticism heavy, this report, we actually came up with a positive of how we could turn it around and do it better for less money, which was why we called the report Better for Women. So I left the RCOG in December 2019, and I rather naively thought I was going to spend the next 5 years of my life cruising into retirement and implementing the other strategies, or rather the other recommendations from this report. And then COVID struck and everything was paralysed. And then all the things I've been talking about got worse. And then in 2021, on the 8th of March, remember 8th of March is International Women's Day, and all sorts of good things happen on International Women's Day in this country. The government launched the call for evidence for a women's health strategy for England. I would argue we didn't really need one, and it was certainly very, very delayed, but anyway, they did it. And it was meant to be published later that year. The only problem was that they didn't realise that they were going to get such an enormous number of applications and comments from the public. So the case for change, I think I've already shown you, and it was that we've got to listen to what women want if we're going to be able to improve women's health outcomes. And it didn't actually get published until the summer of 2022. And the reason for that was that there were so many applications from healthcare professionals and also from women that they just were deluged by them, and they had some pretty unpleasant things that came out of this, like 84% of the, I'm going to show you in a moment, over 100,000 people who responded said that they hadn't been listened to by the healthcare professionals that they visited. And I think that was a real wake-up call for the Department of Health. They had never, ever had so many responses to a public consultation. So as I say, 97,307 female respondents and another 10,000 male respondents, and then 437 written replies from healthcare professionals and academics. And I'm not talking about a sheet of A4 or a screen on Microsoft Word. I'm talking about people submitting theses, lots and lots and lots of pages about how wrong it all is. And then 11 focus groups with women from very underrepresented areas, sex workers, drug addicts, etc., etc., etc. And this is just a snapshot. I'm not going to go through it all, but the top 5 topics that women in this country wanted us to prioritise were not the things that everybody had been talking about, but gynae conditions, postnatal support and fertility, the menopause, menstrual health, mental health. And less than 10% said they had enough information. I mean, I think that's an absolute travesty that the NHS website, which employs more people, or the NHS website doesn't, of course, the NHS employs more people than any other organisation in Europe, and 77% of those employees are women. So the NHS website has to become the best place to go for information. What those 100,000 women told us was that actually they go to Dr. Google or TikTok for their information because they find the other stuff so bloody patronising and so incomplete, and in some cases inaccurate. Anyway, you can read the rest of the slide. It's lots of women not being listened to, and so many women, particularly between the ages of 45 and 65, saying that they were leaving the workplace because they weren't able to work flexibly, or they had particular needs, or they had a disability or whatever, and they quit. And my argument about this to government has been, we cannot afford to have this happen, because you may be able to replace women who are aged between 45 and 65 with another body, but you can't replace their expertise and their skill and their talents. And you can't replace the fact that they usually do the mentoring of the next generation of women, and that they act as role models as well. So one of the things I've learned over this last 18 months or so is that if you want to get something over the line, you've got to find an economic argument that appeals. Now, I find it a bit offensive because I don't really think we should be putting pounds, shillings and pence on women's health and lives. But if that's the game we have to play, so that's why all you could see in the newspapers for a while were these reports about how we can't afford menopausal women to be leaving the workplace because it leaves a big hole in our economy. And I'm hoping that this year and next year in 2024, we're going to make the same argument for menstrual problems, which is so easy to solve if people know what to do. So anyway, the strategy did adopt a life course approach. Perhaps after I've had a glass of wine tonight at the dinner, I'll tell you how hard I had to fight to get some of the very basic things into this strategy. But we got it in, and I think it is quite comprehensive. It's a 10-year strategy. It's incredibly aspirational, the report, if you look at it. There's no plan in it. I think that's what I'm meant to be doing with the team. It's got 8 cross-cutting themes, and you can read the slides as well as I can. But in this first year, we've been really trying to push on access to services, trying to close some of that unmet need I mentioned earlier. Obviously, we have to focus on disparities in health outcomes between women and marginalised women. And I think that's going to be an area where we'll be able to get an economic argument to actually get people to do something rather than just talk about it, and health in the workplace. And these are the 7 priority areas. So right at the top, menstrual health and gynae problems. We've told the ministers now that they're not allowed to use the word benign gynecology. There's cancerous gynecology or gynecological cancers. And there's chronic disabling disorders such as periods and fibroids and all those sorts of things. And then menopause, mental health and wellbeing cancers. I'm particularly worried about how we're going to deliver on the last 2, because I think they are such enormous problems. The health impacts of violence against women and girls. It costs this country about 30 billion a year, the health impacts of violence against women and girls. And for those obstetricians and gynecologists and those emergency medicine doctors in the room, you will of course know that, because we tend to be the first place or first port of call for women who survive those assaults. And then the healthy aging and long-term conditions are also going to be tricky, difficult. Again, I think because of siloed commissioning and the way that the Department of Health works, so there is a major conditions team and they get very cross, and they say, well, what's the Ambassador for Health, for Women's Health doing? That's our bit. And what I'm trying to get them to understand is that we've all got to go on this journey together. And because, as I'm going to show you in a moment, for example, women's cardiovascular health is so very different to men. And because all the drugs have been trialled on men, surprise, surprise, they don't work that well on women, and women do much worse. This is the most extraordinary shot. I mean, it was taken against a black background, and then they blew it up to purple, because purple now is going to be the colour for the Women's Health Task Force. No one consulted me. But then I got appointed, as I say, in June 2022 to try and push this over the line. So why does access to services matter? So in the call for evidence, the women all told us about their awful struggles they were having. And as I was pointing out earlier, most women are going to menstruate for nearly 40 years of their lives. And they usually have 12 periods a year for 40 years of their life. So if they spend a couple of days in pain or unable to go to school or unable to go to their job, that's a serious problem. And it can't just be something, oh, well, it's just a period. We've actually got to do something about this. I've already mentioned contraception, which, as you know, is one of my sort of drum rolls here. The Public Health England have known, well, it doesn't exist anymore, but it's for many, many years we've known that for every £1 you invest in contraception, you get a £9 return on your investment. And if I was to have one thing that I got over the line this next year, in year 2 of the priorities, it would be post-delivery contraception, because the pilot that I ran in Northwest London during COVID showed that you could actually save £32 if you sent women home with a year's worth of contraception or a coil or an implant in their arm. So this is a massive, massive saving. So the spotlight on access to services was that we committed to encouraging the expansion of women's health hubs, not necessarily new facilities, as I'm going to go on and show you, but a change of thinking, and women need to be able to go. So Sue, you need to be able to go and get your smear and your mammogram and your problem periods or your menopause or your contraception sorted out in half an hour or an hour at most. It's very easy to do, but at the moment, if you came to me for your contraception in my menstrual disorders clinic, I would tell you, oh, I can't prescribe the contraception, I'm not commissioned. And whilst I've got all your clothes off and I'm putting in this Mirena coil for your painful heavy periods or for your menopause management, I'm not allowed to do your smear. This is just crazy. It's just such a waste of money. So these were the year 1 implementation priorities: to encourage women's health hubs, to improve information provision. You'll have to notice, if you go through this list, that you have one that might cost money and the other one that you should be able to do for no money. It's all a bit of box and cox when we've got to get the ministers then to sign them off. Supporting women's health in the workplace, because I think that's really crucial. Care following pregnancy loss, and I'll come back to that. Access to fertility treatment, and to try and stop the postcode lottery of fertility treatment, which is a disorder, it's a disease, and it causes enormous pain and distress for women and men. Improving access to hormone replacement therapy, well, we got those certificates over the line on April the 1st. It was one of the best April Fool's jokes I've ever heard. And healthy aging and long-term conditions and boosting research. So those were the year 1 implementation priorities, and quite a few of them did get it on. I think we'll skip over that. Now, I mentioned something about dementia earlier, and in that public call for evidence, a quarter of the respondents wanted to include healthy aging because they were worried of their experience of trying to care for family members with dementia. And 7% of them said that they wanted to focus on neurological problems. There's an enormous problem in the sense that we just don't address this. We just wait for people to come with the problem as opposed to telling them what they can do, not to avoid dementia completely, but to postpone it for as long as possible. Spotlight on the menopause. Well, we said we'd get a menopause pathway improvement programme, and that's now up and running. This thing that happened on the 1st of April was that I can now go and get my hormone replacement therapy for a whole year for the cost of a single prescription, which is a big move forward. And if you're disadvantaged or you're marginalised, paying for every month or 3 months those prescriptions meant that it was out of order for you. We've got an NIHR menopause research prioritisation exercise, and lots of other things are ongoing. And I mentioned about continence and pelvic floor health. So the NHS long-term plan is now committed to improving access to postnatal physiotherapy. and for all women to have access to those sorts of things out in the community. One of my colleagues who runs a urogynecology service in Croydon in South London has halved her NHS waiting list in secondary care by providing bladder drill exercises and physiotherapy out in the community. I mean, I think Amanda Pritchard would be really happy to reduce her NHS waiting list in secondary care, and we've actually got to get people to think differently about this, so that it's not done necessarily to GP surgery, but it needs to be done out in the community. We don't need all these people going into secondary care for things that they don't need to have done. And we know that the NHS England is now working to improve prevention and identification of pelvic floor dysfunction. I mentioned something about cardiovascular disease. So there are 3.6 million women are living with heart and circulatory disorders in the UK at the moment. And women are 50% more likely than men to be given the wrong initial diagnosis after they have a heart attack. Their symptoms tend to be different. It doesn't tend to be crushing central chest pain. It's often moving pain, or feeling unwell, or feeling nauseous, or fainting. 8,200 women in England and Wales could have survived their heart attacks over the last 10 years if they'd received the same quality of investigation, diagnosis and treatment as their male counterparts. And we know that coronary heart disease kills more than twice as many women in the UK as breast cancer. Hence my point earlier, women worry about breast cancer, and as someone who's had breast cancer several times, I do too. But I'm much more likely to die of heart disease than I am of breast cancer. So gender differences in cardiovascular disease, they're less likely to prescribe certain heart medications, and there is now a wealth of knowledge and literature about this. And it seems rather extraordinary, doesn't it, that all of the cardiovascular drugs in the armamentarium at the moment have been trialled on men. There is now an NIHR policy. I presume it's been got over the line because the chief scientific advisor to the government now is also an obstetrician, a gynecologist called Lucy Chappell. So perhaps she's managed to get them to say that they won't fund any form of medical research that involves trials unless there's an equal distribution of men and women. So spotlight on the menopause. I'm going to move on to that, but move off that. I think it's been very important that the Menopause Workplace Pledge, that Wellbeing of Women, which is the charity I chair, has actually managed to spit out, if you like. We've now got more than 2,500 employers, including the civil service, NHS England, the BBC, Tesco, Bupa, and the Royal Mail, saying that they're going to prioritise this, help women to access things. It's a very good example as well of trying to get people to recognise that if they work in collaboration with others, i.e. with the charity sector and with the voluntary sector, we can get a lot more done. There's usually a tendency at NHSE and the Department of Health to say, oh, well, no, that's our stuff, and no, it's confidential. But actually, what I'm trying to get them to do is say, we can't afford to do that anymore. We actually have to welcome all comers, because we really do need to get some improvements here. So this is me presenting the Menopause Workplace Pledge certificate to Sir Lindsay Hoyle when he signed up for the House of Commons, and he gave a very moving speech that evening last summer about how his wife had suffered so much that he was determined that the House of Commons was going to be a menopause friendly place. And there's an employment programme. I don't think we need to address on about that. So health in the workplace, there's lofty ambitions about how we're going to improve things in the workplace. I keep telling them all that they really need to think about the NHS, because we're losing women hand over fist who don't want to stay. And as I say, 77% of the NHS workforce are women. And I don't think that we treat them very well at all, but we're trying to improve that. Our suggested workplace improvements could include open discussions of women's health issues at work, flexible working arrangements, which is now much more acceptable post-COVID. So, you can always get something good out of a crisis if you look hard enough. And I think the ability to work remotely may not be ideal, but it certainly means that a lot more women can continue working. They need better access to occupational health and mental health support. And we've already talked about workplace adjustments, etc., for the menopause and other things. So I really hope that this year we'll be able to get that same sort of consideration for women with menstrual problems and get them fast-tracked to solutions, as opposed to sitting on waiting lists and unable to function as a result of it. So health in the workplace, the government then provided £2 million, which is not a lot of money, it's a drop in the ocean, for 16 projects to be focused on reproductive health in the workplace. Wellbeing of Women got a couple of those grants, and so they've certainly been doing lots of things with community programmes and also with virtual reality. Work in the civil service and the NHS to improve support for staff. The Department of Work and Pensions, I nearly fell over when they told me this, recently appointed a menopause employment champion, because they've woken up to the fact that actually if we kept women at work rather than quitting work from the ages of 45 to 65, it would do an awful lot more and will be of great economic benefit, you see, so it's the economic argument again. And the Health and Wellbeing Fund, as I said, is just about to launch the results of its spending and the work in the health. I think this is a duplicate slide, work in the civil services, and Helen Tomlinson, who's the menopause workplace champion. Now, the thing I wanted to speak about now briefly is the introducing women's health hubs, because when we did announce with the year one priorities that this was going to be the top one, I got into terrible trouble. I was summoned by the GPs, and so apologies to any general practitioner in the audience, and told I was very naughty and that they didn't want their lifestyle, and they didn't, no, not their lifestyle, they didn't want their work plans all disrupted by these new hubs. And I said, well, they're not going to do that. There's an awful lot of unmet need out there. There's plenty of disease to go around. And then there were other people that got very cross with me in secondary care and said, well, but if you're going to do all this stuff in these health hubs, you know, we're going to lose our block contract in gynecology. So this, I think, really, ambassadorial role is really about trying to get people to think about the problem differently and recognise that there is a large sum of money that goes into our health service and we've got to spend it better. So some of the case studies of the hubs I think are really interesting. Sue Mann, some of you may know, set up a most fantastic health hub in Hackney in East London, working with some very marginalised and low-income women. And she's organised a lot of virtual programmes there. So they will send out a note to, say, 150 menopause women between the ages of 45 and 65, and they join a platform with a physio and a dietitian and a clinician, a menopause expert and a nurse, and then everybody's able to ask questions. And what they've found is that way you don't just get your question answered, you benefit from everybody else's questions. So for a 90-minute slot, you can go and get an enormous amount. They have been so popular, she's really been swamped. And they're now trying to use that model for lots of other areas of women's health. I mentioned about postnatal contraception in northwest London, so post-delivery contraception. And this happened during COVID, because I said to the clinical director one day, as I was having coffee with, well, we've got a terrible problem. I said, I just saw a woman coming into the antenatal clinic and she's delivered her baby 6 months ago here. She said, well, what can we do about it? I said, well, we need to prescribe post-delivery. And she said, well, what do you need for that? I said, well, I think I need a bit of a budget. And she wrote it on a post-it and handed it to me. So I didn't ask anymore. And I called back Red Mullins, my Pixie, who's now my consultant colleague. And we set up a training programme for the midwives and junior doctors. And as I say, when they then looked at across northwest London, which delivers about 300,000 babies a year, if you look at everything that you've impacted by improving birth spacing, for every £1 you spend on the post-delivery contraception, you save 32 across the sector. So the answer is, if you want something to sort out, you need to take the woman home, send the woman home with the baby and the new baby in one arm, 12 packets of desugestible in her handbag or her rucksack, a coil in her uterus or an implant in her arm, and they're all compatible with breastfeeding. So the hubs, so we're trying to work towards one-stop shop models. I mean, I realise you can't do everything in the same day, but many, many women, I think, would be happy to travel to somewhere if they knew that when they got there, they were going to get what they needed. We think we're going to be building hub and spoke models as well, because we know that there are going to be some things that require more complex services that can't be in every single one. But I think that the vast majority of integrated care systems, remember there are going to be 42 integrated, well, there are 42 integrated care systems now across England, are going to have virtual hubs, which do first, basically, I think should be triaging. So you go to the hub for a virtual consultation and you can then be pinpointed, well, not pinpointed, signposted to where you need to go for whatever you need. And to support that, we've formed a network of women's health champions across the 42 ICSs. So I now have a named person I got into awful trouble about that as well. 25 million was handed to me, well, not handed to me, but handed to the Women's Health Team, once again on International Women's Day, the 8th of March, 2023, to say, here we are, you can have this for the health hubs. And the health hubs, well, the ICSs all went, that's hopeless, you know, we need much more than that. But it's effectively the money, which is split up in by 42. Everyone set up something as a proof of concept. We've been trying to engage people across the system. The evidence for health hubs is extraordinary. If you've got the time to read any of it, I'm very happy to send you much more detail. And as I say, trying to get collaboration rather than competition, and start trying to get people to stop fighting for these pots of money. There's some really good case studies that you can, or places that you can visit. Liverpool has done a fantastic job in getting long-acting reversible contraception sorted out right across their sector. Asha Castley-Wells' unit in Manchester, in the community service there, is quite extraordinary. She's single-handedly almost reduced the waiting list really, really dramatically. And a lot of hubs now that are starting up are going to emulate that particular model. I particularly like this one because we've held a load of webinars over the last few months since the money was, we were pushing on the implementation. And so some of them, like Asha's, had been up and running for about 15 years, whereas this group in Leicester, which I thought was really interesting, had only started in January, and they realised that there was no point having a physical hub at all, that they actually had to get their healthcare professionals to go out to community groups, to faith-based places like the mosques, synagogues, and churches, because many of those groups just did not trust conventional health professionals. And they really have done a fantastic job on virtually no resource, just by thinking about it. And they talk about, we're going to not start, instead of talking the talk, we're going to walk the pavements and go out to the community as opposed to sending them to places. So I think there's enormous benefits of health hubs. And just turning to the right-hand side of the slide, undoubtedly they improve access and reduce inequalities. They obviously are much, much more efficient. And I think that's important because one of the things I've noticed in visiting so many of the different models is how proud the staff are to be working in a place that actually is obviously benefiting women. So I think there's going to be a whole retention of the workforce there as well. So improve patient experience, and it is going to save an awful lot of money. So I'm coming to the end. How are integrated care systems approaching women's health and their strategies? Well, as I say, I'm on their case all the time. I've been to visit all 42 integrated care systems, either virtually or in person. It's quite hard work. And it's very funny, the Department of Health, they employ me for 4 days a month, but I think I do 5 days a week. But anyway, not to worry. But they are really facilitating collaboration across commissioning and providers. And so that's what I've been saying, that there's plenty of money in the system, but it's stuck in silos. We need to pull it out. And therefore, the responsibility of these integrated care board chairs and chief executives is going to be really important. So if anyone's interested, if you go on to england.womenshealth@nhs.net, all you need is an NHS email address, and then you can you can actually see all the resources. There are webinars, a discussion forum, and a calendar of events. It's actually really, really an informative part of the website. I don't think I need to talk to you about the timelines because they've just increased my contract for another couple of years. So I'm just going to go back a slide here. Hang on. These are the potential priorities for year 2 of the strategy, engaging with women in underrepresented areas in the call for evidence, improving access to contraception, emphasis on post-delivery of menstrual management, care pathways and support for endometriosis, and then also something that I feel very strongly about, improving healthcare for women in the justice system. Well, I visited several prisons in the last few months, and it is just awful what women are having to put up with. And also trying to introduce a licensing scheme for non-surgical cosmetic procedures, which I'm dead against, trying to focus energy and time on that. But I think one of the ministers has been badgered about that. So I'm going to finish now, but just by reminding everybody that the Sustainable Development Goals are nearly finished. You know, they ran from 2016 to 2030. And the one that I think is really particularly important is SDG 5, which is ensuring gender equality and empowering all women and girls. And as I say, time is very short. We're running out. When we get to Christmas this year, there'll only be 6 years left. And we're not doing too well. I suppose COVID held us up a bit. But if I just take maternal mortality globally, there will be another 300,000 deaths because women are pregnant in the world this year, when we look at the statistics, and 214 million women who've got no access to family planning. And if you look at this slide, we're talking about the lifetime risk of death due to pregnancy. And so if you're a girl in Chad, your lifetime risk of dying, and remember you have no control over whether you get pregnant because you don't have any family planning, is 1 in 8. So in Chad, you don't go to a baby shower, you go to a farewell party at 35 weeks because 1 in 8 of them won't come back. Compare that to the average maternal mortality in developed region of 1 in 7,300. And for reasons I've never really understood, the best place in the world to be pregnant is Sweden. So your chances of dying there is 1 in 17,500. So one of the things that I think we need to, I was taught that women die in the 21st century in childbirth, as one example, because of the lack of clinical facilities, or because of cultural reasons, or for economic reasons, or because they don't have access to healthcare, or the healthcare that they can access is poor quality. And I've now concluded that all of that is a bit of a red herring. What really the real reason why they're dying is because they don't have gender equality. And what we need to establish gender equality and reach SDG 5 is female literacy and political will. And I've now concluded that those are the two things that actually change things. If you educate women to the end of secondary school, they will always have better health. Irrespective of their next door neighbour who is much wealthier than them, they will never ever reach such good health unless they finish their secondary education. This was Ban Ki-moon, or the late Ban Ki-moon, when saying that when we empower women, we empower communities and nations and the entire human family. And this is someone I'm very, very fond of, one of my mentors, Mahmoud Fatala, who is the father of the safe motherhood movement. The last time I saw him was in February in Cairo. And one of the things that he was talking about there is that imagine a world where no woman is denied her right to health. And he believes that the OBGYNs of the world really are able to make that happen. But he then goes on to say, which I thought was a rather lovely quote, empowerment is the enabler to achieve this, but it's not available in pharmacies. Women have to find it elsewhere. And that brings me on to another wonderful book that I think you really should read, called Women Hold Up Half the Sky. It comes from this Chinese proverb, and it's written by Nicholas Kristof, who's a New York Times columnist. And in this book, which is harrowing in places and joyful in others, he talks about the fact that every century that goes in history, we look back on it retrospectively and think, well, what was the big moral imperative of that century? So in his interpretation, he says, well, the 19th century now is known because of the moves to abolish slavery. And the 20th century attempted to address racial discrimination. And we're all going to be judged from the 21st century as to whether we achieve gender equality. And this is somebody else who I've been a great mentor to me, Flavia Bustria, when she was the deputy director of the WHO. When she had, I think, a really marvellous quote about how the right to health is a human right and the health of nations is determined by the health of its girls and women, because we do all that pulling things together stuff. So I think that what the health strategy is trying to do is get past equality, because you can have equal opportunities, but you don't actually necessarily reach the bar, and moving it towards equity. So those people who are having particular problems reaching that bar really need to have a helping hand up. So I know that when we're talking about these things, everyone says, well, it's so enormous, I'm not going to be able to do anything about it. So this is one of the nicest birthday cards my daughter's ever gave me, which I don't know if you can see it, can you? There's a little girl waving a stick at a little boy, and she's saying, I'm not bossy, I have skills, leadership skills. Understand? So I would say that we've all got to advocate for change, and everyone here in this room or on Zoom today or in the next door room has a role to play, because the purpose of advocacy isn't to go and do clever things. All the things I've talked about are very simple. None of it's rocket science. But the purpose of advocacy, I think, is to change hearts and minds and persuade people that they've just got to behave differently. And hopefully I have persuaded you that The reason why we need a women's health strategy is when you get it better for women, you get it better for everybody in society, and you also get it better for less money. Thank you.
Thank you very much, Lesley. Very interesting talk. In some respects, it's sad that I feel as though obs and gynae or the services have declined. I remember as an SHO, you did give a year's contraception, you did do all these things. So my concern there, I must admit, also when I first came to York, we were not offering infertility on the NHS, which or investigation was quite a concern. But I do hope we do, first of all, get back to that stage and then improve again. So that's very good. One thing you said right on one of your earlier slides was that if you would go to York Station this evening and ask what everyone's going to die of, it would be cirrhotic disease. Yes, certainly. I'd like to, Lesley is happy to take some questions if anyone would like to ask anything. You've stunned everybody. Kasha.
You mentioned earlier on that menstrual problems are very easy to sort out. And I just remember that there was some European countries, Spain, but let's think that we get 2 days off a month as a sort of no questions asked because they are something entitled to be off.
Yeah, well,
Just answer the question next door.
So the question that's being posed is, I mentioned that menstrual problems are an enormous problem in terms of women not being able to work, and the question where the lady in the audience was saying that in Spain there is a policy to give women 2 days off work if they need it for during their menstrual period. Well, we tried that, if you remember, in this country about 6-8 months ago. It was thought to be, could we have menstrual leave or menopause leave, and it got a resounding no from the government. And should I say the right wing? Anyway, it got a resounding no. I think they are relatively easy to resolve. If, as I was saying earlier, women have 12 periods a year for 40 years of their lives. So I don't think it's unreasonable for every healthcare professional, when they see a woman, to say, and how are your periods? It's an easy question to ask. And you don't have to know an awful lot about it. But if the woman says it's awful, I can't go to work, or I'm flooding, or then, well, okay, you need to go and get some special help. But most women are told that they've got to put up with it. So I think there's an awful lot one can do. And now that we've got things like Mirena devices and tranexamic acid, you can really, really make a big difference to women's menstrual problems and their pelvic pain problems. And that's the bit that keeps them from going to work. So I'm not sure that we'll get this government to give us time off. But I do think that if we were to get the health hubs up and running, and we ran a campaign, which I'm trying to do with my charity, called Just a Period, where we actually get women and girls to understand that it's not normal to be incapacitated. It's not normal to not be able to go out of the door because you're terrified of flooding, or you can't wear light-coloured clothing at that time of the month because you're just frightened what might happen. There is help out there, and we've got to, I think, signpost, which costs nothing, signpost women to the places they need to go to get the help they need.
Going on to a health economist in the corner.
One of your former colleagues, Nick Bosenkamp.
Nice to see you.
Congratulations on contacting all the 42 ICS. Could you name 2 or 3 who've got veganitis? Seems to be better than the others.
Well, I'm trying to get them really enthused. They get very cross about the fact that some of the ICSs are catering for 400,000 population, and the others, another one next door, will be catering for, 3.5 million. But I keep trying to say, well, I don't say the real truth. The DH thought it was going to be far too difficult to work it all out in an equity basis per population. But the idea is that everybody's got the opportunity now to have a proof of concept hub. And my hope, and the thing that I keep banging on about when I visit them, is once you've got it up and running and you see what you're going to save in terms of the reduction in secondary care referrals and just traveling around and unnecessary appointments, it's going to be very evident that this is how you need to move your money around the patch. But it's a really tricky one for these integrated care leaders, because in order to get the money to sort those things out, they've got to take it off other people. And turkeys don't vote for Christmas, do they? So I think it's not going to be easy. So I don't think it's going to be easy, but I think there is enough evidence there, and there's enough analysis that's been done now to demonstrate that it is a very cost-effective way of doing it. And I return to my point as well, Nick, about the fact that most of the time women are going to health services, they're not sick. They're just trying to keep up their maintenance so that they can get back to those other roles in life. And I also think that the other thing we've got to do, and this is a bit I keep talking about with the Women's Health Champions, is we've got to make women part of the solution. Because if I tell Sue what she's got to do, or suggest that she does this, that, and the other to help with a particular problem she's got, not only does she usually do it, but she doesn't keep the information to herself. She goes and tells everybody else. She'll tell her sister and her daughter and the next door neighbour and the woman in Waitrose or Lidl or wherever you go shopping. Women talk about these things because they are the doers. So I think that we need to make women part of the solution. I don't mean that they've got to do self-care, but you'd be surprised how much they can do if they know what's normal and abnormal and where they can go to access for good help.
Richardson, a psychiatrist.
Thank you very much. I mean, I think that gave a very good overview. I mean, it's about health for women, but it's actually about health for everybody. The overarching is always, once again, you prove what a complete waste of time commissioning is. But secondly, the idea of hubs seems great to me, and especially when they're reaching out into the community. And the triage business, which will get us away from this obsession we have with waiting lists, where we have skilled people signposting people in the right direction for their needs. But the sort of question I want, have you made any inroads with the hubs with the domestic violence? Because they are, I mean, as you said, it's everybody, but it's not only the women, it's the children.
Yeah.
And the health effects on the children. So it does seem, I'd like to see it move up a bit from 7.
Yes, absolutely. And it's down there because it's down there because it's the thing that we've got to get to eventually. Well, not eventually, but I think it's going to be the most difficult to demonstrate sustained improvement. But you ask a very good, so I'm sorry, there's a gentleman I can see on Zoom who couldn't hear. So the question is, how are we going to make some sort of inroad into improving domestic violence? The questioner is a psychiatrist, and of course, psychiatrists see an awful lot of the sequelae of domestic violence, particularly amongst the children from those families. So I've done quite a lot of work with Women's Aid, which has done a lot getting survivors to talk and to talk to parliamentarians. But the problem is that for every time you have a Me Too movement, you have it's not all men movement. One of the things that I often show when I'm talking to people about domestic violence is a clip from a TED talk by a guy called Jackson Katz, who's an American male, and he talks about how the only way that we're going to be able to resolve or get past misogyny and domestic violence and abuse is to remind everybody that if you make a comment about it's not all men, that is a little bit like me saying that because I'm not abusive to black or brown people, that racial discrimination doesn't exist. So the whole business about not all men, well, of course it's not all men, but the reality is that domestic violence and abuse is predominantly male on woman, male on female, I should say. And that when you look at homicides in this country, that although women are a small percentage of the overall homicides, 80% of them are murdered by an intimate partner. And so when I hear politicians saying, oh, after the Sarah Everard death, oh, well, women mustn't, they must get a bus or they must hire a taxi or they must, I think to myself, who are you kidding? I mean, most of them are not bumping into a rogue police officer on Clapham Common. Most of them are being murdered or abused at home where they're meant to feel safe. So it's an enormous problem. So perhaps we could talk a bit later about how we can get a cultural shift into thinking that it's actually everybody's responsibility to call it out when they see it. Because it starts in small ways and then it escalates, doesn't it? And you must have seen that so much. But the children that come out of these families are I think, I suspect you would agree.
Thank you. Sarah Watson, GP.
Thank you very much for a very interesting and thought-provoking talk, and lots to take away from it. I just wondered about these women health hubs. Who sort of setting them up? Is it driven by secondary care, or is it primary care? Or I'm just interested to know if I'm a GP, but obviously it's working across with secondary care.
Yeah, so I think it's going to resolve a lot of the need for secondary care, because a lot of the things we're talking about, you don't need to go to a secondary care facility. And the reason I got into trouble with the Royal College of GPs is that they thought that I was going to, or someone was going to have some diktat about how every GP practice has got to become a women's health hub, which it definitely isn't, because A, it doesn't need to be, and B, not everyone's going to want to do that. And the needs, the rural needs are going to be very different from urban needs to local, you know, or seaside deprived or whatever. So it's got to be, the model's got to suit that population. But the answer to your question is that if you contact your ICS leaders, they will be making plans now about either a virtual or a hub and spoke model, or a more sophisticated one for investigations and diagnostics. So if I was to have, but the key is coming back to this thing about really experienced people doing at the beginning of the pathway to signpost women to where they need to go. So if I was to, for example, if you were to come and see me on a Zoom call or a Teams call, and it transpires that you need a prescription for something, I can email your pharmacy and deal done. And then if we also included patient-initiated follow-up, that you know that you can come back if you need it, that saves an enormous amount of money as well, because women don't come back and sit in clinics or sit waiting for a virtual call if they don't need it. They get on with their lives. And if during that consultation we decide that you need to have some blood tests or some imaging, then you're going to need to go to hub model X. And if you're actually going to need, for example, if you come with postmenopausal bleeding, then we have to do something about, looking inside your uterine cavity, because even if a scan says there's nothing sinister, we've still got to sample the endometrium. So there's no point you going through those steps. You might as well go to a place that's got outpatient hysteroscopy under anaesthetic, of course, under local anaesthetic. So I think it's really a question of that. So contact your ICS leaders and find out who is going to be championing that. And if you tell me exactly where you are, I will find out from my secret list of women's health champions who you can contact. I got into terrible trouble about women's health champions.
Find one of our ex-obs and gynae registrars who abandoned us and went to become a GP.
Women's health champion, you're right with this, Sarah. We're trying to do them, really thank you. I mean, that's so inspiring. We're trying to deliver an awful lot to the community. It's really interesting we can't mention strategy and how in Sweden they have better outcomes. Well, Sweden have integrated health and social care. They don't have siloed where they can have a fixed capacity where they can offer 30 lark to that area, 50 to that area. So I guess one of the challenges to this is all the right stuff. It's great, we want to make it happen, is maintaining skills and trying to build the workforce for the future. Because of course we have 1 year grants for this, 2 year grants for that. You can't develop a sustainable long-term vision. So I guess, can you give us some hope that some of that's going to happen?
I think so. Well, it is a 10-year strategy, and I started 18 months ago with an 18-month contract, and nobody consulted me, but they sent me a letter last week saying, oh, we've extended your contract to December 2025. So I rang up HR. I said, well, that's rather funny, because there'll be another government by then, but apparently someone has decided that we need a bit of continuity. So I'm going to continue being the ambassador until I say something that makes them kick me out. But I do think there'll be more money, and I do think that also that we will find that when we get the proper levers at ICS level, there'll be nowhere to hide really, because they've actually got to deliver some of this stuff. The facts speak for themselves. You know, if we were to implement post-delivery contraception across the country, which I know is a difficult thing because you've got to get it trained into midwifery curriculum and into the all sorts of fights with the nursing and midwifery council are looming ahead of me now, and people saying, well, how are we going to get paid for this? But the actual devices or the pills are a drop in the ocean compared to what can be saved. So if we have, what is it, 700,000, 800,000 maternities a year? So if every woman post-miscarriage, post-abortion, post-baby was to be offered long-acting reversible contraception, we would save an awful lot of money. And then we could plough that into cardiovascular health and osteoporosis and frailty and dementia work. So all I'm saying is that this stuff is so predictable and we could just get it done much, much better.
Right, starting with, we'll go with Mike, a urologist, retired urologist.
Politics, in the last 10 years, how many secretaries of state have you met? And did any of them impress you?
Well, I've met a lot actually. I met 3 when I was president, and then of course last year I met 4 in quick succession. That was quite interesting. And also this role is appointed by the government. So I was interviewed by Boris Johnson. Perhaps that's a bad thing, or I don't know, or it's a good thing. But I do. So Sajid Javid impressed me, and also although I didn't always agree with him, Jeremy Hunt impressed me as Secretary of State because he really did care about patient safety. And some of the others are not so impressive, shall we say.
Dr. Dutton is respiratory consultant.
Thank you for a great talk, and it's a great initiative. In other fora, transgender voices are very vocal. Did they figure in your consultation exercise, and how do they figure in your initiative, or is it just going to be a pragmatic organ check?
No, my daughters were very worried about what was going to happen and was I going to be cancelled, and I said, well, I can't be cancelled. And they said, oh mum, you don't know what you're talking about, because you know you put something on Twitter and that's it. So I only ever tweet positive things, and I don't do it very often anyway. But the answer to your question is that there is a disclaimer at the beginning of the strategy, in the middle and at the end, which says although we refer to women, that this is any individual, however they identify. I've been waiting for the person that sort of says, you know, why is it called a women's health strategy? And it hasn't happened so far. But then I think that's possibly because there are several challenging questions I get, to which my response is, well, I don't really care what you look like. If you walk through my clinic door and you need my help, you will get it. And that's the one reason, well, it's probably the main reason why I stay trying to do 1 day a week's clinical work. For 2 reasons. First of all, I think I've got to be credible. I don't do very much anymore, but I do a little bit. And also because I hear what's wrong with the health service from, you know, the porters and the car park man and all these other things. And it's really very important. And particularly in the operating theatre. So I just go and do a day surgery list. These are very small cases, and I've got plenty of minders around and very clever people around. But it does stop. I mean, I had a conversation with the current Secretary of State a couple of months ago, in which he had this new idea. I said, well, I don't think we can do that. I said, because this will happen. Well, how do you know that? My advisors have told me it's going to be very good. And I said, well, if I'd done that in my day surgery unit list yesterday, this would have happened. So it's the law of unintended consequences. And they have to listen to that. I'm sure there are similar analogies in your respiratory world.
In relation to the health in the workplace thing, did the considerations include addressing sexual harassment and sexual assault in the workplace? And if so, how do you think is the right way to begin to go about it?
Oh, so the question is, does the strategy look into sexual harassment in the workplace, and how would we best go about it? Well, I think I'd turn the question round. What would you like to see in the workplace? I mean, I was interested in the ministerial and the civil services response to the publication of the Royal College of Surgeons report, which demonstrated that something like 80% of the women that they'd interviewed who were surgeons had been sexually harassed, and one had been, you know, many of them had been raped by male surgeons. And everyone was sort of saying, oh, you know, it's almost like, well, which country are we talking about? Well, actually, it's this country. So there's a lot of denial, I think, about this going on. And then there's well, it's not all men, and you know, I don't see that. But I think what I would say is that it's all of us calling it out all the time. And the way I found it best to do that is, instead of reacting angrily to something that someone's saying, is sometimes repeating their comment back to them, saying, I think you've just said, is that right? Yeah. And it does actually make them stop. But I don't have an answer for you, apart from the fact that I think the problem is incredibly important. Well, the problem is important, and it is incredibly prevalent. And all of us have a responsibility to do something about it and to call it out, painful or uncomfortable as that is. Everyone's exhausted now.
Yes, Leila, an obstetrician.
No, I work in York. Thank you very much for the inspirational talk first. I work in York and I'm trying to introduce the postnatal contraception. And I've encountered a lot of barriers. Amongst them, we don't have many midwives, the morale is really low, and there are many other priorities that come before this. So from your experience, what do you think the enablers, the most important enablers that you have to account to make it happen?
So the question to those of you on Zoom is, Leila is an obstetrician in York, and she's trying to implement post-delivery contraception, and she's meeting a lot of barriers. So there are barriers, of course, and the midwives are seriously overworked and under-resourced and understaffed. And I think the importance is how you give the message. So I persuaded the midwives that I'm working with, and I didn't get 100% of them to follow, that actually this was going to be career enhancing for them. Because, so what I did was I trained them how to put in implants and coils, and then said, well, you know, now you can do the whole journey, because you can book the woman in the antenatal clinic, you can deliver her, you can pull out the placenta, you can stitch up her bottom, and then you can put the coil in or the implant in her arm, and you don't need any more pesky obstetricians to harass you, do you? And that you can get on and do it. And then I negotiated with a friend of mine who happened to be the president of the Faculty of Sexual and Reproductive Health to give me a whole load of cut price certificates. So it comes down to money, because it may not be so much of an issue for myself to register for the faculty certificate every year, or to go on the catch-up training program, but it's a big expenditure in a midwife's thing. So we've got to facilitate that stuff. And I've had a meeting, which I can tell you didn't go too well recently, when I proposed that the faculties looked at their business model and thought of a different way of raising money, because to be charging for buying a certificate that says that you're bona fide at work to be doing this, for that to be a barrier because of expense is madness, isn't it? So I think it's multifactorial, but I'm serious about, we have to get the Nursing and Midwifery Council now to include it in their training program, so that then becomes something that everybody does. And I think also the other thing that I would say is that if we paid midwives and obstetricians to deliver babies and look after women, as opposed to filling in forms, you know, we would go a long way, not just to a better patient safety or maternity safety, but we'd also do a lot more about our workforce retention. So why don't we get the forms filled in by other people? Or, and I've been talking about this for years and years and years, why don't we have one portal into which all the information goes? And there are very, very clever techie people out there, and I'm not one of them, but I'm sure they'll be able to extract the bits they need. But at the moment, if you have a disaster in your maternity unit, you've got to notify 9 different bodies, haven't you? That's a terrible, terrible waste of your skill. Terrible waste. So, I mean, as I kept saying to, it was Hancock, actually, he thought he was the techie genius. And I said, well, in which case, you know, why can't you sort out a way in which a midwife or a obstetrician, or the ward sister or whatever taps in the thing for when they're notifying an incident, and then you find people to just pull out the bits that need to be gone rather than do it 9 times. So, oh, it's too difficult and this, that and the other. But what amazed me is that 6 months into the COVID pandemic, I got my vaccine passport on my telephone. And my NHS, so, you know, where there's a will, there's a way. I mean, you can do it if you want to do it enough. So I'll talk to you afterwards about it, because there's some ways to actually persuade the midwives. Cake and chocolate help as well.
Yes. I think we'll stop questions now. I did warn you, Lesley will call a spade. And also, I'm glad to see that your daughters have sussed you out beautifully very hard. And I'd like to thank you today. It's been a very thoughtful, very interesting presentation.
Thank you.
And look forward to this evening. And thank you very much.
Thank you. Thanks for inviting me.